And get started. This is the third meeting. Today's the 9th of March. Ken Fleming, co-chair of Medicaid Oversight Board. And if you don't mind, to silence your phones, we would appreciate that. We have a pretty extensive agenda covering several bills that's been either filed or have going through the process, and then we have the cabinet to talk about a state plan amendment regarding school-based Medicaid services. So with that, let's go ahead and call roll.
Senator Byrd, Senator Carroll,
Here.
Senator Meredith, present. Senator Richardson, Representative Heverin, Representative Mosier, Representative Williams, Representative Wilner,
Here.
Vicki Yates Glisson, Holly Harris, Joe Petrie, Steve Shannon, Senator Douglas, Senator McDaniel, Representative Bowling, Representative Petrie, William Baker,
Here for William Baker.
Laura Sedkamp, John Hicks, Lisa Lee, Sheila Schuster,
Here.
Stephen Stack, Tom Stevens, Co-Chair Fleming, Co-Chair Adams.
DJ, I'm here for Joe Petrie.
We're all here. All right, we are having a quorum. We're dutifully charged to go ahead and start the meeting, and there is no minutes, so we don't have to approve any minutes at this point. What I would like to do is just change the order of the agenda, and I'd like for Representative Neighbors to talk about House Bill 689. There she is. Representative Neighbors, I think you know the routine. If you don't mind, just go ahead and after you introduce yourself, and you do have a guest, do you not?
Yes, there should be two available on Zoom.
Okay. Would you want to go ahead and start and then bring them in? I'll leave it up to you.
We can go ahead and bring them in if they're available.
Go ahead and have them introduce themselves.
Yes. The guests of Representative Neighbors, if you go ahead and introduce yourself, we would appreciate it.
Hi, I'm Dr. Heidi Murley. I am from St. Elizabeth Healthcare in Northern Kentucky.
I'm Russ Ronaldo. I'm the CFO at Owensboro Health.
Great. Thank you all very much for continuing to appreciate your time and working through in terms of having going through Zoom. So, Representative Neighbors, you have the floor.
Yes, my name is Representative Amy Neighbors. I represent the 21st House District. Thank you, Chair and Co-Chair and members of the committee for the opportunity to bring to you House Bill 689. House Bill 689 provides the statutory authority for Kentucky to implement a Medicaid state-directed payment program for physician and non-physician professional services delivered through qualifying hospital-affiliated groups. The bill directs the Department for Medicaid Services to seek approval from CMS and, upon approval, to implement the program beginning January the 1st, 2026, with retro payments for that calendar year. The goal is simple: to strengthen access to care for Medicaid patients, especially in rural and underserved communities, while supporting physician workforce retention and aligning reimbursement with quality outcomes. Right now, many physicians and non-physician practitioners affiliated with teaching hospitals are not eligible for existing state-directed payment programs. That creates a funding gap, particularly for providers caring for large Medicaid populations. House Bill 689 allows Kentucky to use an existing federal mechanism to help close that gap. This program is estimated to generate approximately $29 million per year in new federal Medicaid dollars by allowing the qualifying hospitals to receive enhanced Medicaid payments for professional services, which they currently do not. Importantly, it does not require general fund revenue. Payments would comply with federal law and would increase Medicaid reimbursement up to the Medicare rate. Participating providers would also be required to meet state-identified quality metrics consistent with our existing programs. This legislation is about access, stability, and workforce support. It leverages federal dollars, strengthens our healthcare infrastructure, and supports the providers who care for some of Kentucky's most vulnerable citizens. At this time, I'd like to turn it over to Russ Rinaldo, CFO with Owensboro Health, and Dr. Murley with St. Elizabeth Hospitals for any further comments or any answers to questions you all might have.
Thank you, and I appreciate the opportunity to speak. I also appreciate the ability to be here by Zoom. Owensboro Health is a rural health system in Western Kentucky. We have 3 hospitals. One, our large hospital is the Soul Community Hospital, and the 2 others are small Medicare dependent, Medicare low volume hospitals. All 3 of our hospitals are the only source of healthcare in the counties that they serve and in the region that they serve. So many times we're the only access for a lot of healthcare without traveling for our citizens. And one of the things that health systems are experiencing is increased subsidies on the physician practice side. It is expensive and hard to get physicians and practitioners to rural areas to practice.
Excuse me, I apologize for interrupting.
Sure.
We're having a hard time hearing you. I'm really
sorry.
straining, and my hearing's not that great. Would you mind just speaking closer to the microphone?
Okay.
That would be most helpful. I got most of it, but I don't think
Okay.
folks may.
Can you hear me? Can you hear me better now?
Yeah, that's perfect. You don't have to
better?
start over. Yeah, just go ahead. I
Okay,
apologize.
all right. And
Thank you
so,
for your patience.
Our from the Medicare side, we've actually had a 7.5% reduction in Medicare payments over the last 5 to 6 years. Those payments are supposed to cover salaries, malpractice, and practice expense. None of those are going down. We have to pay physicians more. Our malpractice is going up. So this program would help us continue that access in areas. I talked last week about Twin Lakes. We've had OB practitioners that have retired. We've had to, in order to keep that service there, we've had to incur a lot of subsidies to bring new practitioners in and shore up that service, which we intend to do. But this program gives us the ability to continue that access. There's quality metrics in there to allow us to chase things on our physician practice side, and there's no state general dollars in this program, and I just appreciate the consideration of the MOAB committees to potentially forward this.
Thanks, Russ. And I'll just add a little bit to that. So St. Elizabeth Healthcare has the only inpatient facilities in the 3 northernmost counties in Kentucky, as well as a critical access hospital in Grant County. We function as a competitor within the greater Cincinnati market. However, for Kentucky Medicaid, we are certainly the safety net hospital for our communities, those communities that we serve. So we continue to struggle with the same things that Russ mentioned, the rising cost of physician talent. With Kentucky being a low wage index state, our federal funds that we get from Medicare and Medicaid are quite low, certainly don't cover the cost of care. And this additional funding will help us at least partially bridge that gap. I'm the CEO of the medical group, St. Elizabeth Physicians. We care for Medicaid patients in both inpatient and outpatient settings. Our Medicaid percentage in the area is roughly 16%. So that's a huge drain on our system if we don't have better funding. We have had HRIP, Hospital Rate Improvement Program. We've had the benefits of that on the inpatient side. However, as we've seen from the big beautiful bill funding, that funding is expected to be cut from the average commercial rate down to Medicare rates over the next several years. That'll have a significant impact on us. From our perspective, it would be extremely helpful, again, without accessing any general fund dollars. This is something that would be entirely funded through us, through UK, through other participating health systems in U of L and the federal government to help bring additional dollars into Kentucky to help this population.
Any other comments? No.
I don't believe so.
Okay. This will let the board know. Representative Neighbors and her guests did make a presentation to the health services and it passed unanimously. The General Assembly decided any type of Medicaid-related services bills need to come through for us to review and so forth. And even though we would have a more of a preemptive approach, given this is a new committee, we're trying to get everything together. We're going through this process right now. It might change down the road when it comes to hearing Medicaid-related bills during the interim. But in any event, I know we have a question, or Representative Wilner.
Thank you, Mr. Chairman, and thank you, Rep. Neighbors, for this really good bill. I was happy to vote yes for it in committee, along with everybody else on the Health Services Committee in the House. And I just wanted to clarify, I think the reason, and I think actually this was covered, but the reason there's no cost to the general fund is because UK and U of L and the 4 systems that will benefit from this are paying the state.
That is correct.
So thank you. And this is good. Again, I'm very happy to vote yes on it. I'm aware that we have other health systems that this won't benefit, who are going to be subject to the same restrictions, the same reductions in pay. So that's certainly no reason not to support this, but I do hope that the Medicaid Oversight Advisory Board will think about what we're going to do to help those other systems. But this was, I think, really great, and thank you for bringing it.
You're welcome. We good?
Is there any other questions from the board for Representative? Go ahead, Chairman Meredith.
Thank you. Not a question, Mr. Chair, just a comment and some future thinking of this group. Mention was made about us being a low wage state, and that on a national level. And one of the challenges we're going to be facing going forward is we know our Medicare payment rate in Medicaid is substantially lower than other states, significantly lower. And I think maybe we need to lobby our congressional delegation to address that inequity because it's substantial. And while we're feeling the effects of H.R. 1, reduction of Medicaid costs, that burden is disproportionately felt by us because we are reimbursed so much lower than other states. So again, this be a topic for discussion as we move forward, but I think that could go a long way towards addressing the inequities that we see within the system. Thank you.
You're welcome, Chairman. Very good points. I do not see any other questions from folks, so thank you very much, and thank you for y'all to coming in and zooming in. And appreciate your information.
Thank you.
Thank you. Okay, next on our agenda is Senate Bill 201. Senator Douglas, if you don't, and you are making your way down to the table, and Senator Douglas, when you have the opportunity to get settled, just introduce yourself and give us sort of a rundown of Senate Bill 201. And you have the floor, sir.
Thank you, Mr. Co-Chair and Madam Co-Chair. I am State Senator Donald Douglas, District 22. Senate Bill 201. I also want to thank you all for allowing me to present this morning, and I want to thank all the members of the Medicaid Oversight and Review Board. Senate Bill 201 is a bill that really is meant to improve how we deliver health care here in the Commonwealth, and also how we follow up with the health care here in the Commonwealth. Most people don't know, but currently, as healthcare providers, we can only see a patient for one issue during a particular visit. That's it. We all will acknowledge that persons from different demographic populations have different challenges. And so we're going to look at the Medicaid population, and let's take a quick look at some of those challenges that we often cite. That is transportation. We talk about support system. We say certain groups don't have much of a support system at home, and there are a lot of home care challenges. We look at diet, which is one of the things that our Make America Healthy Again task force is taking a look at. exercise, motivation, or even access to some of the exercise equipment, some of the psychosocial support that this group finds challenging, and even some of the mobility issues. And there are a lot of different mobility issues in this space. I'm just going to talk about some of the problems that our current system presents and some of the things that Senate Bill 201 will address, and then I will let my colleague who will introduce himself. I'll let him go over some of the nuts and bolts of the bill itself. Some of the problems that we have is that patients who are recovering or have recovered or even have problems that aren't changing from a previous visit, we can only talk about one thing. So we can address what happened at the last, or we can address what they want to address now, but we can't address any more than that. And that really creates an issue. The current system requires multiple trips to the healthcare provider just for treatment. You can only see them for one thing. It requires multiple patient care slots. And what that means, we often talk about how we don't have enough physicians or we don't have enough patient care slots. This is a hindrance to patient care slots because you can only treat one thing. And so patients have to come back to have something else treated because there are a limited number of slots. And this also slows the information gathering from the global patient care issue. Most healthcare providers look at healthcare in a global way, not just an episodic way. And when you can only treat one thing, this really hurts how we do medicine. Now, some of the solutions that I think Senate Bill 201 will address, it will allow not only new but current issues to be addressed. That actually saves money. It actually saves money. It allows for more opportunity for education because you will allow the healthcare provider to explain to the patient population how one particular issue can either cause or affect the other issues. It actually opens up more patient care slots, and it actually saves the patients a lot of money because they don't have to make multiple trips to have things taken a look at. They're going to have to be taken a look at anyway. It expands the ability to obtain, as I say, global information, and it also helps us address and even plan future treatments. And believe it or not, it helps with no-shows because when patients need multiple trips and we look at all the other challenges, often there's a huge number of no-shows, Mr. Chairman. It allows follow-up to address previous unresolved complaints or even non-compliant patient issues. It gives us an opportunity to say, why did you not do this? To get that information. It also, and finally, it allows the provider to get more global information. That is, be able to ask, we're treating this part, now you're having this issue. How do those fit together? How can we handle that? And it actually allows for more accountability by the healthcare provider to be able to ask the patient, what are you doing? Why aren't you doing it? Is there anything we can do to help with that? So with that being said, I'll have my colleague introduce himself and let him speak.
Thank you. Thank you, Chairman Fleming and Chair Adams and members of the board. My name is Cody Hunt, and I'm the Director of Health Policy for the Kentucky Medical Association. And so to explain the background and the intent of Senate Bill 201, Senate Bill 201 seeks to correct a long-standing coding issue. Senate Bill 201 would ensure that any coverage limits set by the Department for Medicaid Services or the MCOs would not reduce coverage to fewer than 2 evaluation and management service units per provider, per patient, per day. Currently, there is language in the Medicaid Administrative Regulation 907 KAR 3005 that states coverage for an evaluation and management service shall be limited to 1 per physician, per recipient, per date of service. And so practically speaking, what does this mean? Let's say a patient goes in for their annual wellness visit, and during the course of that visit, the patient presents and the treating provider discovers a new untreated chronic condition that requires additional evaluation and clinical decision-making beyond the scope of what they are there in the office being treated for. And so in this case, would be the annual wellness visit. So when this additional evaluation and clinical decision-making is provided and the level of care administered would suffice to the level of an additional evaluation and management code being coded, the practices serving the Medicaid patients are, per the existing regulation, technically prohibited from following the nationally adopted CPT guidelines and appropriately coding the level of care that's provided. Now, I will say, prior to Senate Bill 201 formally being filed, the Department of Medicaid Services has amended or filed an amendment to that regulation to fix this problem. We've had conversations with DMS and Commissioner Lee over the course of the last couple of years by way of the Physicians TAC as well as through the Medicaid Advisory Council. And so the problem will be hopefully addressed through the regulation, but we do still think that there needs to be a statutory fix to prohibit a policy similar to what's been in place for a while now to be prohibited from happening again. I'll also note that at the moment, I believe that all of the MCOs do allow for these encounters like I described, where there would be 2 E&Ms billed. They do allow them to be coded correctly. Now, the payment policy does differ across the board by MCO, but we're not trying to address the reimbursement. We just want the correct coding policy to be established. That would conclude my comments. Happy to answer any questions if there are any.
Senator Berg.
Thank you. Thank you, Mr. Chairman, and thank you guys for this bill. I guess I have 2 questions, if that's okay. So I think your last statement may have answered my first question, which was, what is the fiscal impact? I mean, how much is this actually going to cost us in further reimbursement to physicians? But my first question actually was, on the private payer side, can you bill for and get reimbursed for more than one evaluation and management code per visit?
Yeah, so we don't think that there would be any fiscal impact because this bill does not affect the actual payment policy or the reimbursement. That would still be up to each of the MCOs to decide how they want to handle that. For example, Anthem comes to mind. When they were previously in MCO, the way that they handled this was they reimbursed 150% of the billed code. So if you build multiple E&Ms, they would pay out 150%. Some will only pay 50% of the 2 billed, and so it kind of varies. And we don't want to address the reimbursement issue. We're just trying to say that practices can correctly code this, and ultimately, it'll be handled on the payment side by the MCOs how they choose.
Currently, Senator Berg, as you know, in many practices, healthcare providers are told to bill for the greatest reimbursement. We know that. We know that occurs. The hope for this bill is that it will actually decrease the cost because your providers are actually taking it on the chin. It would be easier for them to have the patients come back and get the full reimbursement for those codes. There will have to be some negotiation and some talk with our with our insurance companies about how that reimbursement may change or may not change.
Got you.
And I think that'll have to come down the road.
Thank you. I think that answers my questions. Thank you very much.
Representative Mosier, you have the floor.
Yes, thank you, Mr. Chairman, and I apologize for walking in late, but I am familiar with this issue and have worked with the cabinet in the past to just do this through regulations to try to correct this coding issue. I just really have a comment more than a question. I think that the likelihood of keeping costs down is greater with this provision. We will see patients less often in the office, and it's also a convenience issue for patients. Who wants to come back for 2 visits if you can take care of the same issue in 1 visit? So I like this provision. I'm glad that you have brought this before us, and I look forward to working with you. Thank you.
Chairman Meredith, you have the floor.
Just a comment, Mr. Chair. I don't know anything that's a better illustration of how broken the system is than this particular policy, because it's directly taking care of sick people, not maintaining the health of the population. And I think you're building my case for having a new model of delivery that's based on capitation rather than fee for service or billing for services, because you're not allowed to treat the whole person. And you're right, it will increase efficiencies. It'll have better utilization of dollars, but we got to take a while to get there. But again, appreciate you making my case. Thank you.
Dr. Schuster.
Senator Dr. Douglas, I want to thank you for bringing this because on the mental health side, it also is an issue. And I will just point out, and I never see the LRC making a mistake, but in the summary of this bill on the LRC website, it says management services to fewer than 2 units per physician per recipient per date of service. So I had my hackles up already. But then when I looked at your good bill language, it obviously says per Medicaid participating provider, which would be all of us that are Medicaid providers. So thank you for that. And I hate to point out an error ever done by our LRC folks. But this is important for the whole person care. And I think it will save patient wear and tear and save us some money. And it, more importantly, will give us better health care for folks. Thank you.
And Dr. Schuster, I would just say probably the reason why it says that is because the Medicaid regulation is in the I think it's the physician services section, and in that regulation it's specific to physicians, so that may be why that language is the way it is.
Well, then I guess, may I follow up?
Yes, ma'am. Go right ahead.
Well, then I guess I have a question, Cody. Should the Medicaid reg be more, talk about Medicaid participating providers?
The way the amendment to the reg is now, it would just remove the prohibition generally. So I think that would probably take care of it for other providers too.
All right. Thank you very much. Appreciate it.
Okay. Dr. Stack, you have the floor.
Thank you, Mr. Chair. Yeah, so the reg is permissive of all of this, and so it would address the question that you brought up, Sheila. Thank you.
Is there any other questions for the senator from the board? Very good. Having on, thank you very much, Senator, for coming in and bringing this. I think it's a very outside the box thinking and try to find efficiencies and effectiveness in providing delivery care. And thank you for being on the front lines and doing those services.
Thank you, Mr. Chairman, and thank you, board.
Okay, next on the agenda is Representative Riley. It's House Bill 583. If Representative Riley, if you make your way up to the table. When you get settled, feel free to introduce yourself and your guests. I know we have some people online, and I think one of your guests is quite familiar, for the good.
Thank you, Mr. Chair,
Yes, sir.
and thank you to the board for allowing us to present House Bill 583 today, which relates to the school-based Medicaid program, especially in regards to school nurses. I will go ahead and let my guests introduce themselves, and then we'll get back to the bill.
Good morning. I'm Emily Beauregard, the Executive Director of Kentucky Voices for Health. And good morning. My name is Gannon Tagger. I am here today representing the School Nurse Special Interest Group for the Kentucky Nurses Association.
Again, thank you, Mr. Chair and committee and board for hearing this. As some of you know, I worked in school systems for a number of years. I'm a retired educator, served as a teacher, an assistant principal, and a principal. And one of the many duties I felt like I had when I was an assistant principal is, beyond all the other duties I had, I was a nurse. I had to do all kinds of deals with students when they had injuries and all those type of things, and never had the availability of having a school nurse at that time. And I retired about a decade ago. And I think one of the best things that's happened to schools since then is the ability for them to have a school nurse. We oftentimes think of nurses dealing with physical issues, sickness, those type of things. But we know that our world has changed a great deal, and one of the many things they also deal with is mental health. So this bill is going to give school nurses much more freedom to do the things that they need to do in regards to Medicaid. I learned a long time ago in the school business and other times that when you have experts, you get out of their way and let them give information and make decisions. So I'm going to turn it over to the experts right now and allow them to talk about it. And Gannon, if you could go ahead first and explain your involvement in this. Thank you.
Hi, everyone. Thank you again for letting me come in virtually today. And as I said, I am representing the Kentucky Nurses Association School Nurse Committee that has, we've been together for a long time, working on behalf of getting school nurses in every school, all day, every day in the state. This bill will allow, as Representative Riley said, it will allow nurses to expand the ability to get reimbursed for the services that they are already providing. So much of our school nurses are, they are providing services through IEPs and getting reimbursed for that, but they're not getting reimbursed for services that they're providing on a daily basis outside of those students with IEPs. What we know is that students that have school nurses in their schools have decreased absenteeism, they have higher grades, and general overall higher health as well. And so we know that students who stay in school do better in school, and overall, long term, will do better educationally and overall better economically for the state is the hope. And so allowing this bill to go through would allow more resources for schools to have nurses. So that's, in addition to that, Representative Riley indicated that school nurses can identify mental health issues, and that's really important as well. So what we know is that students who have some things going on at home, maybe are suffering from anxiety or potential depression or other issues, often present with very vague complaints such as headaches and stomach aches, especially in the younger population. So not always seeking out somebody for mental health issues, but they will go to a school nurse, and the school nurse is able to identify what's going on. They are able to connect that student and those families with resources. And again, just get the students on the right path and the families where they need to be. So overall, so much research over the years that school nurses provide better outcomes for students when schools have the nurses in the building.
Thank you, Gannon. Now we'll have Emily.
All right. Well, thank you again for the opportunity to speak in favor of House Bill 583 this afternoon. As Gannon said, Kentucky Voices for Health school nurses, we have been advocating for a nurse in every school all day, every day for many years now, because we know that students have to be healthy in order to develop, to grow, and to learn to their fullest potential. We also have strongly supported Senator Wise's legislation that set a goal of having one mental health provider for every 250 students. When students have access to this timely support, whether it's for physical or for mental health, they miss fewer classes, families face fewer workday disruptions, and educators can focus on instruction. So reflecting on these goals today, we're not quite there yet. Schools need approximately 600 more mental health providers to meet that ratio of 1 to 250, and about 40% of our schools still lack a full-time nurse. Schools and their third-party billers who support them are also leaving federal Medicaid funding on the table, which is what House Bill 583 intends to correct. Medicaid and K-CHIP cover approximately half of Kentucky students. The reversal of the Medicaid free care rule under the Bevin administration in 2019 gave schools the opportunity to bill Medicaid for any medically necessary service as students need, not only for those with a 504 plan or with an IEP, an individualized education program, but also for these other types of healthcare needs that many students have. And that change opened up a meaningful way to support overall student health, including nursing and mental health. Now, what makes House Bill 583 unique, a unique opportunity for Kentucky in this moment, it complements both the Rural Health Transformation Initiative. It complements Senator Meredith's Senate Concurrent Resolution 9 to explore accountable communities for health. And it allows schools to put up the state match to draw down federal funding, which is becoming increasingly important in the environment that we are in with the recent federal cuts to Medicaid funding. So the school state match actually comes from salaries and other administrative costs that are already in their budget. So any additional services that they would bill for would be a cost to the school's budget, but it would not be an additional cost to the state budget. The only cost to the state would be for some additional onboarding and training of school staff to make sure that staff understand how to bill appropriately. And that's estimated to cost the state about $111,000 a year for Medicaid staff. So the bill, just broadly, requires that if a school is already providing services, that they bill for the services that are medically necessary for their Medicaid enrolled students who have parental consent. It requires third-party billers to bill for any of the codes that are in the current technical assistance guide that Kentucky creates. And it enables school nurses to receive training for oral health prevention, which is already within their scope, but they do need training from the Department for Public Health in order to provide those services and to bill for them. And I'd be happy to answer any questions.
Just a second, Dr. I do appreciate you bringing this bill, and I believe you speak very well, Emily, on the need in terms of having school-based counseling services. When I went to my elementary school that I attended many years ago, the amount of volume and the complexity that comes to one person in the school is very, very hard to manage. And I think having those additional training services is at a very, very, very nominal cost to the state is so important. So I do appreciate you bringing this to our attention. Senator Douglas, your floor.
Thank you, Mr. Chairman. Just a very quick question. Emily, does this apply to both acute and chronic medical issues?
Yes. The short answer is yes. Schools could bill for any medically necessary service. Now, they can only bill for services that they have the staff to address. So if they have a school nurse, it would be within their scope of what they would be able to treat.
Thank you. Thank you, Mr. Chair.
Yes, sir. Senator Carroll, you have the floor.
Thank you, Mr. Chairman, and thank you all for the presentation. Help me understand with the revenue that would be generated from this. You have a nurse that is paid by the school, and some of the revenue would help to cover normally what would be the state's portion of Medicaid. The school would cover that portion. Would the nurse's salary be adjusted based on the revenue that's brought in through billing Medicaid?
This really operates no differently than billing for IEP services. Schools hire the staff that are going to provide these services, whether it's a nurse, a mental health provider, another type of provider. The salary and the administrative costs that are within the school's budget to support those positions are essentially the state match. And so the billing is also a cost-based billing by unit of time. So for the nurse's time, that would be, the unit that would be billed. And that would all be based on the salary and the administrative expenses that the school is paying for. Does that answer your question?
It does. Thank you. Thank you, Mr. Chairman.
Dr. Schuster, have the floor.
Some of you may know that I worked with K&A for about 8 years to try to get this to happen. So to color me really excited about this. And Representative Riley has been so supportive of this. I didn't realize you had acted as a nurse, Representative Riley, but we appreciate that.
Well, I didn't have the certification, nurse. I promise you that.
Several of the speakers have talked about the mental health part. I will just say one thing. I've testified before about this. If you have even an elementary student, but certainly a middle or high school student, and they are dealing with a mental health issue, they are never going to raise their hand and say, I need to leave to go see the school psychologist. I mean, it just isn't going to happen because there's so much stigma. but they will raise their hand and say, I need to see the school nurse, and nobody will think anything of it. And that school nurse is the best traffic cop that you can have in a school, because they have all the training to listen and to look beyond what the student is saying. And that's what you need. And then hopefully we have the mental health professionals right there to help with that child. So this is huge on physical health, but this is really, really big, folks, on mental health for our students. Thank you so much for bringing this.
Thank you, Dr. Schuster. Chairman Meredith.
Thank you, Mr. Chair. Just a quick comment. Just another example of how healthcare doesn't exist in silo. Obviously has an impact on the health of the student, but also impacts average daily attendance for school, which affects their funding, but also workforce participation, because now parents potentially don't have to take off work to come and get their child and take them to the doctor. So I think it creates a lot of savings that we don't see. And to Senator Carroll's point, under this new model that we're talking about, whatever savings are realized will be distributed amongst the partners in these new entities, and the school system would be one of them. So as we improve the health of the population, they could share in those savings, generate more money for school purposes. So thank you.
Co-Chair Adams, you have the floor.
I was just, thank you all for this. I was just reading, is this for APRNs, RNs, LPNs? Does it cover everybody and they just have a different billing code?
There are different billing codes, and all of the providers that you just listed can be and are currently working in schools throughout Kentucky.
Okay.
Schools have the choice of, which type of provider to hire, but the technical assistance guide that was put together by the Medicaid department includes billing codes for all of those providers.
Thank you.
And more.
Yeah, I just wanted to make sure we weren't boxing ourselves out of any kind of level of healthcare professional. Thank you.
Okay, is there any more? Oh, Dr. Burke, go ahead.
Thank you again, Mr. Chairman. Billing is a little complicated. Do the individual schools actually bill and follow up and show documentation, or is that something we're able to do for them as a collective? How does that work?
Schools do the billing with generally the support of a third-party billing company. There may be a school here or there that does the billing themselves. The vast majority use a third-party billing company. But it's still complicated because the school is the one having to document the medical necessity and to provide all of the information to the billing company to complete that claim. It's incredibly complicated, more so for schools because it is a cost-based reimbursement. So there is administrative claiming. It's not just a simple fee-for-service. And that administrative claiming, I think, is what has discouraged some schools from participating or from maximizing their billing because it's just simply very time-consuming and can be complicated. So having additional training from the Department for Medicaid Services, that additional technical assistance for schools will also help them to better document and more fully bill for the claims.
Very good. Did you have a question?
Well, I just got one more brief
Yes.
comment, and it kind of goes along with what Senator Meredith said when he indicated that about parents not having to come to school to get their child and a school nurse being able to take care of it. It also allows school personnel to be able to do their job. As I stated earlier, I felt like I was a nurse at the time, and I had to take away from my other jobs because of that. So I think this also allows highly trained people, which school nurses are, to do the job in the proper way and prevent other people from having to do that. Thank you.
Very good. Senator Douglas, go right ahead.
Thank you, Mr. Chairman. That brought up just another quick question from me. Is there going to be a portal or somehow this information is transferred or gets back to the student's primary care physicians?
Right now, most schools, as I understand it, use Infinite Campus, which has a medical record component. Some schools have a separate medical record, electronic health record that they use and can share information through that separate electronic health record with community providers. when schools don't necessarily have that EHR set up, there are more manual ways that the nurses or other providers will share that information. But it's unique to every school.
Thank you, Mr. Chairman.
You're welcome, Senator Douglas. Any other questions from the board? Well, I know Representative Riley. I know you're a doctor on the basketball court, but yeah, I understand your challenge in terms of medical issues.
Yes, very much. Thank you.
Emily, I just want to verify something with you. You mentioned the ratio of 1 to 250. That's currently, or that's the goal?
That's the goal.
That's the goal. And what are
Currently,
we at now?
it's closer to 330. I could get you the exact number, but it's somewhere in that ballpark.
Okay, at your convenience. There's no hurry, but I appreciate that.
Absolutely.
And you said statewide 600 individuals that are needed.
That's the estimate,
Estimate.
that I've heard is that to get to the ratio of 250 or one provider for every 250 students, we would need 600 additional mental health providers.
This is outside of Medicaid, but what would be the, I guess the impact from a salary standpoint and benefits and all that stuff when you bring on 600 people throughout the state to make that whole? Do you have any idea, or roughly thoughts?
I don't know that I'm the right person to answer that question, but what I can tell you is that with Medicaid billing, you're never going to cover the full salary. You will offset that cost significantly because, as I said, about half of our students are covered by Medicaid or K-CHIP, the Kentucky Children's Health Insurance Program. And for that reason, we could be billing for a lot more of the services than we are today.
Okay. Thank you.
Thank you.
Okay, thank you very much. Appreciate it. Okay, we have two more items on here. I am going to go ahead and sort of I try to substitute description for House Bill 488, which is Representative Deanna Gordon. She was not able to be here. She did present this approach that deals with assisted living to this committee, I think back in September. And she basically articulated that we're 1 in 3 states do not offer Medicaid services when it comes to assisted living services. There's roughly an average cost per room in skilled nursing facilities between $12,000 and $14,000. This could be reduced by going to assisted living to around $3,400. And this will basically could translate to about $100 million annually to Medicaid spending. So I just wanted to, I guess, make that official in terms of having this bill presented to the board and what she was trying to accomplish. It was introduced last year. I need to touch base with her, what her thoughts are about trying to get this particular bill through the process this session. But I just want to make sure y'all are aware that she wasn't here, but I wanted to present this to the board. So I can try to answer any questions you might have, but I will open it up. All right, very good. Okay. The other bill is House Bill 2, which is looking at and reviewing the whole Medicaid program. And there, as y'all might know, it's already been through the House and it's in the Senate now. The whole concept with the Medicaid was looking like basically two approaches. One, to address the House Resolution number 1 that came from the federal government back in July of this past year. And we need to embrace, react, and accommodate a lot of those that law into our particular program. The other part of this bill deals with the program integrity and so forth. Since that introduction, there has been I've had several conversations with folks, and I've also talked with my co-chair in regards to addressing some of these issues that might come up in terms of the Senate making some modifications and toward to do that. One, and I'll mention 3 of them. One is a hardship provision when it comes to unemployment rates for a county that right now the way the bill is written of 10% or more if they reach an unemployment. what we're doing, we're going to be changing that, or I'm going to suggest to my co-chair to change that to reflect the current law that's on the books right now, and I believe it's the federal unemployment rate plus 1.5%. So that's going to be significantly less than 10%. So it's going to be very beneficial to those folks, particularly when it comes in the eastern part of the state. So we'll be making that modification. Also, we just received a letter from CMS about redeterminations. As you know, it's 1 year. We're looking at every 6 months. In the bill itself, it says July 1 of this year. And if that were to held true, then according to the letter, we have to notify folks, or DMS have to notify folks within 90 days. Well, that's 2 weeks. So, so the purpose of have that accelerated is to look at more of a fraud type of a process. So, given that we always default, or we should default to the federal guidelines, we're going to be changing that from July 1 of 26 to 1/1 of 27. So that basically conforms with, with the federal regulations. And there's a couple other small items in there. But anyway, that's what it is in a nutshell. I do want to address one particular item that we've received a couple comments from folks when it comes to cancer and those sorts of very tough health conditions. We are looking at and trying to come up with a way to address those conditions when it comes to medically frail. In the bill, particularly on the federal guidelines, it gives a little bit of a definition from the medically frail, but when it comes to certain items, when it in terms of community engagement, redeterminations, and so forth, the secretary has the ability to make those decisions in terms of what's medically frail. So I just want to let you know that even though there have been some comments like, what about this particular disease? What about that particular cancer, and so forth? If we do that, we can do that, but it really puts the secretary in a box in terms of giving him or her a flexibility in terms of trying to define medically frail. So we want to keep that. Somewhat flexible for the secretary in order to address those situations as it comes up. So in any event, I'll be more than happy to answer any questions the board might have about House Bill 2.
Hello, thank you. Yes, I just wanted to say thank you for the inclusion about the audit that's in section 21. I just think that's extremely important, and especially in light of the fact that when CHFS did not they added limitations on to the passage of House Bill 6 that this General Assembly body passed in 2024. And so I just think it's really important that the waivers be examined and reviewed, and I just want to say how much we are appreciative of that included.
Good, thank you. Anything else? Dr. Schuster.
I have some concerns about the self-determination aspect of this, and I think that a recommendation was made by several groups that the language be an auditable self-declaration document with verification, because I think when you ask for a whole range of verifying documents, you're going to get some discrepancy. And as soon as there's a discrepancy, the person is stuck. And I think we need to be more general in that, and at the same time more specific about how we're defining self-determination.
Thank you, Dr. Schuster. There is a discretion by the secretary for any type of hardships or situations that do come up when there is a conflict in terms of determining that information. So that is always there. In addition to that, there is an appeal process in order to go through and flush out exactly the issues in terms of trying to get somebody to be on the program. It's the intent not to remove anybody off of Medicaid. This is a long-term a long-term addressing a long-term issue on those folks who are in a very tough situation and don't have any other options for healthcare services in order to do that. So, so anyway, I do understand. I understand where you're coming from, but there are two things in there that addresses that.
Follow up, please.
Go right ahead.
My concern is that so many of the folks on Medicaid may have reading difficulties, may not have internet access, the communication, and I think Commissioner Lee would speak to this, the efforts to stay in touch with people and so forth. My concern is that they do their self-attestation or what they think is the appropriate thing. Then what happens to them when all these other processes are going on? Because I think that's where we lose people. And they don't know what an appeal is and that kind of thing. So I guess I'm back to let's make the definition. Certainly I want the secretary to have as much leeway as he can. I didn't realize that he could actually make some decisions about the self-determination. Is that what you're saying, Mr. Co-Chair?
The secretary does have the ability to look at those hardship situations in order to go through that and help folks out. Senator Adams had an additional comment.
Yeah, I think that we still are under the guise of presumptive eligibility as well. So I think that going forward, having that presumptive eligibility as kind of a foundation, then we can move through any hiccups that the process does experience.
Yeah, I appreciate that, Madam Co-Chair, because what I don't want to see happen is people losing their coverage while all of this is going on, and we know that happens. So if the baseline is, and I appreciate the comment that we don't want people to lose their Medicaid. So we don't want people to lose their Medicaid. We have presumptive eligibility, and then we have a definition of self-attestation that makes some sense, but people are not losing their coverage while all of that process is going on. Yes. All right. Thank you very much.
And you're welcome. And just to add a note to that, and I'm trying to use my business approach, my business mind, is that the cabinet, it doesn't matter what cabinet we're talking about, the cabinet can be creative in terms of communicating to try to go through and try to get information out to those individuals that are most affected. So they're not boxed in.
No.
So they have the flexibility and the creativity to use a business approach in order to try to provide that service. But I appreciate your comments.
Well, we certainly saw that in the redetermination when the emergency period left and we had to get everybody recertified. The cabinet was incredibly persistent in using every tool and new tools that they had developed. So I think that's there. I just worry about the impact on the individual and not knowing quite what to do. And again, that's where our connectors and the community health workers and all of the people in the community are so critical to get somebody over there to say, you still have Medicaid coverage. Let's get this worked out. So thank you.
Yeah, thank you, Dr. Schuster. Chairman Meredith?
Thank you, Chairman Fleming. And first, let me start by thanking you and Co-Chair Adams on the Herculean task you've undertaken to get House Bill 2 this far. I know it's not an easy task, but I have some concerns and some suggestions I'd like to pose for consideration. First deals with the cost sharing aspect, and I know this is a requirement of H.R. 1, but the reality of it, particularly for rural providers, is a cost sharing or deductible co-insurance, whatever you want to categorize it, is going to be no payment to providers. There's not any particular standards as how much the cost sharing has to be, and in recognition of that, I would hope we would take advantage of that. Suggesting cost sharing of even $8, $20 pretty much means it's going to be significantly higher than that because there's a cost associated with the administrative portion of that. A $20 copay, for example, or deductible, really it's more like $40, $50 because you've got to obviously try to bill for this. And you recognize, again, you're not going to recover those fees. If you do, it's going to be minuscule. And I really would prefer we try to minimize that amount as much as possible. And I'm suggesting maybe $5 to show that we've made at least a token effort to do something. But again, my concern is this financial burden is going to fall disproportionately on rural providers, small providers, and they're the ones getting most challenged by the provision of HR 1 to begin with. So that's one consideration. The second item is on, I think you've done a great job in trying to get more information from the managed care organizations as to their audit practices. And I wonder if we could have a more detailed report for this body that would look at the number of ongoing audits that are being performed, the number of dollars of clawback. And I'd like to see this on a monthly basis. No reason why they shouldn't be able to do that. But, I'm hearing things like 2 years after the fact, it's been, I won't say settled, but been demanded in hundreds of thousands of dollars. I'd like to see that on a more frequent basis, again, possibly monthly, and possibly the date that an audit is initiated and the date that it's resolved. So we can have some more accountability there. And specific to denials, and this is, I think, to protect providers. I'd like to know how that process works and who makes those determinations, because I've heard instances where an issue that's orthopedic in nature is being reviewed by an obstetrician. Really? And that's not discounting the abilities of an obstetrician, but that's not their field of expertise. So can we have some kind of provisions in there to kind of make that more immediate and more responsive to the particular professions? And last thing I'll discuss is on the data collection. Certainly we need more and more of that, but I'm very concerned about who's going to have ownership for that data and how it flows. Again, if we can direct that back to this body, I think that'd be its greatest benefit. But I think whatever we end up collecting probably should be owned by the Legislative Research Commission. And just like see some assurances that would occur, so we would have ownership for that. And thank you, Mr. Chair. I appreciate you letting me share those comments.
You're welcome, Chairman Meredith. I just want to make just a couple of comments, if you don't mind, on the cost sharing aspect of it. You mentioned about the administrative costs and $8 and such. If you look at a report that comes from the MCOs, when it comes to individuals utilizing a emergency room for non-emergency services, you have a significant amount of money to the tune around $90 million a year that is costing Medicaid in order to provide those services and doing that. So that right there, to have a better communication, to have the MCOs manage that better in order to redirect folks out of that situation into the primary care where there is no cost sharing pay at all in order to provide that services, trying to change the mentality to get people out of the emergency room to free up those immediate services into a primary care where they take a holistic approach. Just what Senator Douglas mentioned a few minutes ago about the 201, they can take a more of a holistic approach to do that. But I understand your situation or your comments. In addition to that, the cost sharing won't take effect until October 1 of 2028. In the bill, it's $20. And that's only applied to a certain group of individuals. And I know one of the things we mentioned earlier is in terms of the folks that are having complex type of medical conditions, we've got to be mindful and thoughtful of that. And I recognize that. And so that's something that we can take a look at. Your point in terms of the clawbacks and having better reporting, spot on. We totally agree that. I've heard a lot of stories. One outfit was like $90,000 and getting clawed back, or they're sitting there, small business. They can't function from a cash standpoint. And so we got to change the dynamics of that. And the data collection, we can talk a little bit further about that. That's going to be housed in the LRC. It's going to include not only claims type of information, but also gather other vital information that will be coordinated and sort of driven by the LRC. And in addition to that, on layering that is that we have a dashboard that's going to be driven by the UK and U of L with this board's oversight to make sure that they include and look at and consider as many things that we look at in terms of performance from the MCOs to the providers to the Department of Medicaid services and so forth. So that's going to be a sort of a good collection of information that we can go through that process. But I'll work with. I mean, I'll have to work with you and the senator in order to look at the ownership of that data and so forth. So I just want to, and I appreciate your comments.
Brief follow-up, if I could, please. Let me share just one anecdotal experience with you. I know we all have our war stories, but here's one of mine. My former hospital in the ED, you'd see about 26,000 visits a year, and costs kept going higher and higher and higher, impacting working folks. So I started an urgent care center in hopes that we could direct that business away from the ER. Because again, if you've got a manpower shortage area, they're coming to ER for primary care. And my goal was to hopefully give the patient a bill of maybe $100, $125 compared to $1,000 from an ER visits. And after I had retired, I was at an event where I heard a couple of ladies talking about their experience of trying to get health care. And this lady mentioned that she had gone to her urgent care center. And the lady with her asked her, so why did you do that? She said, well, it's cheaper. She said, yeah, but if you go to the ER, it's for free. And that mentality is always there, principally because of them talent regulations. That they know that if you go to the ER, you have to be seen. And I don't think that's ever going to change, even with what we consider a minuscule payment. It may be minuscule to the patient, in some instances not. But when you do that 26,000 times, it's substantial. And there's just going to be additional reimbursement decline for healthcare providers. And that's why I just don't think it's worth the effort that we're going to put into it. I understand the intent behind it, but I don't think it's going to change behavior. But appreciate you letting me share that.
Yes, sir. You're welcome. Representative Wellner.
Thank you, Mr. Chairman, and thanks to all for the good comments and discussion. This is helpful. I did want to follow up just quickly on the data collection piece. There was House Floor Amendment 5 that was filed in the House. Actually, Representative Moser and I talked about it. It was, unfortunately, it was out of order because of just a timing issue. But it gets at that data collection piece. It does have it residing with the LRC. And I hope that as this moves to the Senate, folks may look at House Floor Amendment 5 and perhaps some of the other amendments as well, but that one in particular about that accountability piece, because I agree with Senator Meredith. The other thing, the medical frailty, and this is really technical, but it's my understanding that the ability for the Secretary to waive for reasons of medical frailty have to do not with the copays, but with the community engagement requirements. And so I don't know that that there is anything in the federal law that allows that differential copay at the discretion of the state or of our own cabinet secretary. So I hope you guys can look really closely into that, the technicalities of that, because I think the intent is what we all want. And let's, make sure that folks who are really struggling and really impoverished and facing serious medical conditions aren't kept from getting care because they have a $20 copay that they simply can't afford.
Okay. Thank you. Thank you, Representative Mueller.
Thank you.
We have two more questions, and then we're running out of time. We have two more questions, and then we have to get a report from the commissioner on the school-based waiver. And Senator Berg?
Thank you again, Mr. Chairman. I just want to really make two quick comments. Yes, we have people so overutilizing emergency rooms. And yes, we could save a lot of money if we could figure out an answer to that. But guys, part of that problem is that people can't get into a primary care physician. People are waiting literally in the private pay sector, waiting 6 months to get a new appointment with internal medicine or family medicine to have a primary care. And that's people that can actually have insurance and pay for it. So people that don't have insurance or are covered with Medicaid and have less providers available to them, it's a huge problem. And I wish we could come up with a way of specifically almost requiring that everybody be assigned or given, everybody at Medicaid be given an actual primary provider that they have a relationship with, that they could actually call instead of going to the ER. But we don't have that. I mean, even guys among my peer group, my friends, people are going to the emergency room because their primary physicians are not available. And it's happening everywhere. And if there was something, even a state hotline where people could call a really educated nurse before they went to the ER, something. But you got to understand, guys, these people, they're sitting at home. They don't have a choice. They don't have anybody to call. They don't have anywhere to go. And they don't know if this is something to really worry about or not. It's just an untenable position for everybody at this point. And as far as the copays, guys, it wasn't that long ago, because I haven't been here that long, that we actually voted to take these away because they weren't cost effective, because they actually cost the system money trying to collect it. Doctors don't get paid. Patients get disincentivized to seek help in a timely manner. And the whole thing just wasn't working. So I just, I know that the federal government's putting some requirements. I hope that we don't go any step further, because these actually don't help pay for the cost of services, and nor do they actually help people see and get care. Thank you.
Thank you, Senator Berg. Dr. Stack, Secretary Stack, go ahead.
Thanks, Mr. Chair. Just by way of clarification, I don't know if I thought I heard you tell Senator Meredith that the copay requirements would align with H.R. 1. On page 7, some start January 1st of 27, and on page 8, additional ones and changes take place October 1st of 28. Our one suggestion would be the alignment with H.R. 1 would be for them to start October of 28. And administratively, it'd be a lot cleaner just to have them go in once and give people a long enough lead time to code to it, instead of having phase 1 and then phase 2. So just the one comment, if it's possible, to just align with October 1st of 28, and just whatever copays the legislature decides to assign them and have them one effective date. That way it's cheaper for IT costs and more efficient administratively just to do it once on day one. Thank you.
Okay, thank you, Dr. Stack. I appreciate that comment. Okay, last comment is Ms. Harris.
Thank you, Chairman. I just want to say, in recognition of the change with the unemployment rate, that is greatly appreciated. To recognize Eastern Kentucky, our counties are not only the highest in the Commonwealth of Kentucky, but some are the highest in the nation in terms of unemployment. So that's a very positive change regarding that. So thank you.
Senator Carroll, I'll let you slip in there if you be quick, if you don't mind.
Thank you, Mr. Chairman. And I'm not going to get into each issue, but just on the waiver sections, and I think it's 15 and 16.
Right.
There are some provisions in here that I struggle with, and I anticipate amendments being filed relation to this, and that's something we can talk about in depth after the meeting. Thank you.
Thank you. Okay.
Real quick, just one thing real quick. All the listen to that. All the copay comments apply to behavioral health as well. It's a real deterrent for people to go if they don't have any way or they're fearful they can't pay it. So I just want to echo that. And certified community health clinics can address some of that primary care issue as well.
Thank you. They're exempted? Mm-hmm. Yeah, staff just told me that behavioral health is exempted. It's on. the community behavioral health clinics are exempted. Okay, well, I just want to make sure you understand that. Okay, we need to go ahead and move on in the interest of time. Commissioner Lee, you have the floor. If you don't mind, just when you come to the table, just introduce yourself. We all know who you are. They are going to be talking about a state plan amendment to school-based services program.
Good afternoon. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services. And I'm here to talk about a state plan amendment we recently submitted to the Centers for Medicare and Medicaid Services, which is CMS. And as you heard in Ms. Beauregard's testimony and Representatives Riley, there's some activity around school-based services. And prior to 2014, just a little bit of history, prior to 2014, schools could only bill Medicaid for children who had an individualized education plan and for whom there were services outlined in that plan. In 2014, the Centers for Medicare and Medicaid changed some of that those provisions and said schools can bill Medicaid for any service, medical or otherwise, regardless if a child has an IEP, they can bill Medicaid for those services. And as Ms. Beauregard referenced, in 2019, the Bevin administration filed a state plan to say, we want to cover these services for children. We want to cover medical services in the school setting. And then in 2023, the Centers for Medicare and Medicaid Services came out with additional guidance related to billing for services in schools. I did send Mr. Joffrin that specific guidance because it was 184 pages. I didn't know if we wanted to print out one for everybody, but there's a link that you can get to that guidance. So basically what we did is we updated that state plan amendment. It's administrative in nature. We are not changing eligibility. We are not changing benefits. We are just complying with the guidance that came out in 2023 with CMS and making our provisions very clear on what we're doing in that state plan as it relates to school-based services.
I do have a question for you, Commissioner. You said it doesn't expand services, but in the plan it has looks like another 8 different professions that can be be included in terms of providing those services.
Such as counselor. Yeah, those services are currently covered. We're just expanding and making sure that people know exactly who can bill for those services in the state plan, but those are services that are currently covered. They're not only covered in the school setting, some of them, such as a school counselor providing behavioral health services, are covered outside of the school-based setting.
So if this is already included, why is this in the plan?
We updated based on the guidance that CMS submitted, and it does specifically reference school counselors in there and some of those other provider types that should be included. Again, Ms. Beauregard stated that the schools cost settle, so we're specifically stating which providers can be included in that cost settlement area. So it's just updating based on that guidance.
Oh, okay. Is there any questions or comments from the board for the commissioner? Very good. Thank you, Commissioner.
Thank you.
I'm sorry. No, we're good. Okay, we're good. Thank you, Commissioner. Okay, the last couple minutes, we do have 4 people that would like to address the board for public comment. So if I'll state the first person to come up, and then I'll give you who the backup is. Missy Newland, is that correct?
3 minutes.
Okay, after her is Maggie Chisholm, I believe. And just to let you know, you have 3 minutes. And if you don't mind, make sure the mic is close to your face. The light is green. Introduce yourself, and after you do that, you have the floor. You need to pull it up to your as close as possible. Turn it green. Make sure it's bright green.
I see it now.
Perfect. You got it. Thank you very much.
My name is Missy Newland. I originate from Grayson, Kentucky. I now live in Louisville, Kentucky. I clean houses to make ends meet. This gives me flexibility to assist my mom as needed, post-pancreatic cancer and her recent stroke. Thanks to Medicaid, I was given answers after a lifetime of chronic pain and tachycardia. I have POTS, hypermobile Ehlers-Danlos syndrome, and Chiari malformation. This means high pressure headaches, balance loss, and brain fog. These aren't just diagnoses on paper, but daily hurdles I must jump to keep working. Without Medicaid, I wouldn't have access to specialists or the frequent imaging I need to prevent further damage. Medicaid is the only way I can stay healthy enough to keep working. We are already facing skyrocketing electric bills and inflated food prices. So for someone with my list of specialists, $20 copays can add up fast. Cost-shifting copays beyond a federal minimum for low-income Kentuckians would not encourage personal responsibility. It will force us to choose between the needs of our family over our own health. For a gig or retail worker, hours change weekly. Added paperwork requires asking clients to sign income papers 4 times a year. This is not only an administrative burden, it's also an invasion of privacy because I'll be disclosing what kind of health insurance I have to my clients. I know a lot of HB2 is the state trying to comply with HR1. But knowing how many me's are here in the state of Kentucky, we should take a conservative approach instead of rushing into overt compliance. This is certainly not the time to reduce Medicaid state funding. The system is already overwhelmed. We can add on lost hours waiting on the phone for help from an understaffed cabinet, and we have chaos ensue. People won't lose coverage because they're ineligible. They will lose it over procedural formalities, difficult timelines, and missed signatures. We are putting the buggy before the horse by rushing into rigid requirements before federal regulations are even finalized. Copays are higher, reporting requirements in HB2 are more than HR1 requires, and the state's budget proposal in its current form leaves a scary hole in necessary funding. This isn't efficiency, it's a self-induced barrier. I ask my lawmakers to slow down. There are human lives attached to these bills, not just dollars and physical years. We exist, we matter, we contribute, and we deserve a system that supports our health rather than not giving us a chance. Let's keep Kentucky covered and healthy. Thank you.
Thank you very much, Ms. Newland. Appreciate your comments.
Thank you.
Maggie Chisholm, and then right behind Ms. Chisholm is Mike Nguyen. And Ms. Chisholm, I think you've talked to the A&R committee, if I remember. Is that correct? Yes, ma'am. And if you don't mind, just make sure the mic is close to you with the bright green light on. And just introduce yourself for the record, and you have the floor. You have 3 minutes.
Oh, there we go. Okay. My name is Maggie Chisholm, and I have lived what happens when policy discussions do not keep pace with real life. Behind every number is a real family whose lives are shaped by the system this board oversees, and for many of us, waiting is not a privilege we can afford. My daughter Evie was one of those people. Evie was born in 2016 with hypoplastic left heart syndrome, and by the age of 4, she had already endured 3 major open heart surgeries. She also depended on a Medicaid waiver, and even with her extensive medical history, I had to fight every year to prove that she still qualified. I also had to fight to be approved as her caregiver and went beyond what was required by submitting detailed documentation of her medical history, letters from 2 of her cardiologists, and records of her medications and surgeries. I did everything I was told to do and more. I was still denied. I ultimately had to sue for the right to care for my own child. And while my denial was eventually rescinded, it was not because of new evidence. It was reversed because it snowed. Twice. Which begs the question, if the decision could be reversed that easily, why had I been forced to navigate so much red tape in the first place? In August 2024, at 7 years old, Evie was hospitalized with heart failure and placed on the transplant list. A month later, I received notice that she was at risk of losing her Medicaid waiver because she was not, quote, utilizing services. And the very condition that qualified her for care became justification to take it away as she was dying. as she was fighting for every breath she took. My daughter was being penalized for being too sick to survive the system designed to help her, a system that makes no exceptions for hospitalizations, which has still not been addressed in HB 2 or its amendments. Evie passed away on November 13th, 2024. And 13 days later, 5 days after I buried my child, I received a text message reminding me that her coverage would be canceled on December 1st. Families across Kentucky are already navigating complex systems while living in a medical crisis. Time is not measured in policy cycles or fiscal years for us. It is measured in hospitalizations, in medical decisions, in days. Sometimes it is measured by counting heartbeats. Kentuckians deserve a system that protects us when we are at our weakest. Because if policy only works for those who can wait, then it is not working for the people who need it most. My family prayed for a miracle that never came. We prayed while facing a mountain of paperwork. I ask this board to ensure that oversight of Kentucky's Medicaid system reflects the realities families face, build policies that recognize crisis, build systems that prioritize clarity, compassion, and stability. Build policy for Evie. Thank you.
Thank you, Ms. Chisholm, and we, our thoughts and prayers are with you, and I'm sorry you had to go through that process with your child in her situation. So thank you very much for coming.
Thank you.
Mr. Nguyen, and then our last public comment would be from Mr. Hogan. Mr. Nguyen, if you don't mind, just make sure the mic is close to you. The green light is bright. And introduce yourself, and you have 3 minutes.
Thank you very much. As you said, my name is Michael Nguyen. I'm the Director of Community Programs for Grace Health. We are a federally qualified health center located in southeastern Kentucky. And it's my second time to speak before this board. And I really sat here today just amazed and grateful to be from the state of Kentucky, because the work that you're doing here, you're already discussing and healthy debate on topics that are very near and dear to our heart and that impact our patients. So I appreciate that so very much. As a leader working within a community health center in southeastern Kentucky, I do feel that deep responsibility to speak of the real world impact that the proposed changes in House Bill 2 would provide, which include maybe possibly funding cuts beyond minimum mandatory copays for low-income patients, and the significantly stricter reporting requirements that would have on the people that we serve. I want to take a moment just to advocate or be a voice for a gentleman that we met just last week that you'll find maybe has impact for what's being discussed here today. One of the security guards at our clinic happened to see a man walking in the woods in behind our clinic. He followed him out into the woods and found out that he was living in a tent behind our health center. And so he goes in the clinic, grabs our community health worker. They sat with this man out in the woods to discuss his situation and entice him, maybe tempt him, pull him out of the woods into our health center. They were able to give him food. They were able to hand him over to a connector. They enrolled him in Medicaid. His coverage was active in that moment. He was able to see a primary provider that day. They also scheduled him with a behavioral health provider, and he's scheduled to enter into a recovery program, all because of the ability to access that program that day. And so because of that, Travis is what I thought was he was on the path to either an ER visit because of his health situations, or he was on his way to Knox County Jail. But because of that ability to access those services that day, because of the self-attestation component of Medicaid, he was able to get on the path to better health. So as we're sitting here today, this man's life has been impacted by these benefits. So for our region, Medicaid is not an abstract budget line. It is actually a lifeline that allows children to receive preventative care, working families families to manage chronic conditions, and older adults to remain stable and independent. In communities like ours, where poverty rates are higher and access to transportation, specialty care, and private insurance is limited, Medicaid fills a gap that no other system can. Changes that go beyond the reasonable program integrity measures would not simply reduce spending, they would reduce access to primary care, to behavioral health services, to dental care, and to life-sustaining medications.
Mr. Winfield, sorry to interrupt you. We're already over about 45 seconds, so if you have like one or two more sentences, I would appreciate that.
Okay, let me just go to the back. Again, we appreciate the work that you're doing, and let you know that the healthy debate that's happening is an inspiration I get to take back home to southeastern Kentucky and tell them about the work that's being done here. Thank you.
Thank you very much. I appreciate your comments.
Mr. Chairman?
Yes, ma'am.
Can
go ahead.
they actually need me in another committee for a quorum. So if it's okay, I'm going to bug out.
And thank you, Co-Chair Adams. Mr. Hogan.
Yes.
Make sure the mic is close to you. The light is bright green, and let us know what your name for the records. And you have 3 minutes.
Thank you very much. And it's not lost on me that I am the only thing between you and adjournment, so I will make it brief. Doug Hogan is my name. I'm the Government Relations Director for the American Cancer Society Cancer Action Network here in Kentucky. Mr. Chairman, Madam Chair, members of the board, we really appreciate your time and attention this afternoon. ACS-CAN is the nonpartisan advocacy arm of the American Cancer Society. I always like to let people know what we are. We work at the state as well as federal and local levels on policies that we feel will reduce the cancer burden in our communities. For us, access to health care coverage is a key factor when it comes to preventing, catching, and treating cancer. Nationally, Medicaid covers 1 in 10 adults with a history of cancer and 1 in 3 children diagnosed with cancer. So it's very important from the ACS-CAN perspective. The way we read the bill, HB 2 requires Medicaid enrollees to pay that maximum copay beginning in January of 27, and that's only about 9 months from now, while federal law allows that to come into play in October of 2028, about 2 years and 7 months from now. So we encourage that area of the bill be changed so that there's not any potential unintended negative consequences for cancer patients who utilize Medicaid services. We're also concerned that the look-back timeline for enrollment could be another barrier for care. HB 2 has a longer look-back at re-enrollment than federal law, and this provision could lead again to more cancer patients really not having timely access to care or having to forego that care. We sincerely appreciate all the hard work that's gone in to HB 2 and all the hard work that continues to go into this process and your all's work with that process. We would just say that we think the best course of action, though, is no need to rush for implementation. Wait for the federal guidance, wait with the Trump administration, and move forward with those new guidelines as they come into play. Again, we sincerely appreciate your time this afternoon and want to be a resource as you move forward in this decision-making process from an ACS-CAN perspective. Thank you very much.
Thanks, Mr. Hogan. I appreciate your comments, and the board appreciate you coming. The last thing I just want to mention, and it's a more of a general comment, and that is, regardless of when a bill is introduced into either chamber, it goes through the process. And I would say the high probability that most bills that are introduced usually change. And so this House Bill 2 is not any different from any other bill and going through that. And so it is hoped to have this bill as perfected as much as possible, but still meeting the goals of what we're trying to accomplish and making sure that Medicaid is delivered in a timely manner that has high quality and the most cost-efficient means. So I think that's all of our intent in order to do that. And so, like I said, any bill that's introduced, it goes through this process, and then hopefully we'll have a good product. If not, that's why this board's here, and we go ahead and make any changes as we go forward. Dr. Schuster, I have to be really quick because
I just want to point out that Jason Dunn was going to be here to testify and was unable because of an illness, but his very excellent comments were distributed before the meeting. I encourage you all to look at those because he has some very specific comments that are well worth taking heed of. Thank you.
Thank you, Dr. Schuster, for reminding me of that. I meant to say that, and I overlooked my comment. And there's also another letter in there as well. So just make sure the board has received that as well.